So after that orthodontic surgery, we will start with the introduction to cleft lip and palate. So we'll cover this topic under introduction, classification, principle in the management, techniques of plastic repair of cleft lip and palate, and role of the speech therapy. So cleft is a congenital abnormal space or a gap of in the upper lip, alveolus or palate, and basically it's sometimes the terms are used as this hair lip also, and appropriate term is cleft lip and cleft palate, for example. So the dictionary meaning of cleft is a crack or a fissure or a split or a gap. So the common zones affected by the orofacial clefts are upper lip, alveolar ridge, hard palate, soft palate, and then nose are less common, eyes. Any distress condition for the parents as well as the child born with it, severe psychological and socio-economic implications. Then management becomes a major issue for the healthcare system, and the management for those deformities is challenging and requires multidisciplinary approach also. So during embryology, this is the first week of old embryo. You can see this is following in the nasolacrimal groove is forming, the stomatium is forming, and this is the second one is the 6-week-old embryo. Now this is the 7-week-old embryo, and then the 10th week old embryo. So during this formation of in embryology, but we can say the palatal formation is there. It is step by step. The primary palate is there, then there is a palatine shelf and nasal septum, and slowly they come together and join in between. So any obstruction while joining in between may lead to future cleft. So the classification is according to Davis and Rich's classification. Group 1 is pre-alveolar clefts. Second group is post-alveolar clefts. Then group 3 is complete alveolar clefts. It may be unilateral, bilateral, or a median one. Another classification is by view is group 1, group 2, group 3, group 4. Cleft of soft palate only. This is the easy one. And the cleft of hard and soft palate. Complete unilateral cleft extending from uvula to the incisive foramina, and then deviates from one side extending through the alveolus. And the group 4 is complete bilateral alveolar clefts. So internationally approved classification of cleft lip palate says that group 1 is cleft of anterior primary palate. Anterior means anterior primary palate. Then unilateral left or right, total or partial cleft. Bilateral is anterior or posterior. Then alveolus, total or partial. Hard palate, total or partial. Group 3 is the cleft of posterior secondary palate, and hard palate and soft palate. And group 4 is rear facial clefts, which may extend to the orbit also. This is Kernan's classification. This is a Y-shape structure for the classification. You can see the cleft of nose is there. We can color this unilateral, bilateral, then nasal floor, then lip, alveolus, hard palate, again hard palate, unilateral, and soft palate. Now, what are the basic principles in management of cleft lip and palate? To correct the birth defect surgically so that the patient can have acceptable facial aesthetics, then to permit the intelligible speech, to correct the dentition, to allow normal function and aesthetics. And general management protocol for the cleft patients are immediately after the birth, pediatric consultation, counseling, feeding instructions, because there is a, while feeding these type of patients or kids, they don't develop a suction. Okay, so feeding instruction, evaluation by the geneticist also, then diagnosis and life expectancy of the child and diagnostic test. Within the first few weeks of the life, entire team evaluation is there, including the hearing test also. And after 10 to 12 weeks, surgical repair of the lip, and 3 to 6 months of they can start. Okay. So before age of 1 to 18, the team evaluation and the surgical repair of cleft palate and placement of pressure equalizing the tube should be done. 3 months after the palatal repair, 3 months after the palatal repair, the team evaluation for the speech and language assessment they start. And in 3 to 6 years, again team evaluation is there. Medical behavior intervention is needed. Speech therapy is 5 to 6 years. Lip, nose revision if necessary, or pharyngeal surgery. At 7 years, orthodontic treatment phase. 9 to 11 years, pre-alveolar bone grafting if required. 12 years or little, full orthodontic treatment phase. 15 to 18 years, at the end of orthodontic treatment, placement of implants, fixed bridge for missing teeth, if any. Then 18 to 21 years, when most of the growth is complete, surgical advancement of the maxilla is if required. Then final low nose and lip revision, rhinoplasty can be done in 16 to 18 years only. So principle of management of cleft lip and palate: first rotational flap is there, then advancement or combination. Techniques for plastic repair for cleft lip and palate: the chiliography is the surgical correction of the cleft lip deformity. This term is derived from the cleolip, and raphy is from the junction or the suture. The objective is twofold: functional and aesthetics. Surgical techniques, as each cleft lip is unique, it must be done, a surgical procedure is unique for the patient, and various techniques are used for this. For the margins, to first is the primary repair. Okay, so primary repair or straight line repair, it is the easiest one, but it is not not so common nowadays because of the future scarring and aesthetics to the patient. So this is a clear-cut Z-plasty, you can say. Okay. So these are the various points that 1 will collaborate with 2. Then this 6 point, this will collaborate with 5. 3 and 4 will come down and repair, and 7 and 8 will come down and repair. So it will form like a Z-plasty. Okay. Then another approach is tension operation. In tension operation also, it's a type of Z-plasty with a modification. And in Vine approach is a different rotational flap. The flap is rotation. Flap rotation is done from the philtrum only. Then the most popular one is the Millard operation or Millard rotational technique. So as you can see, this is the 0.5 and this is 0.9. So there is a rotation of the flap. Okay. The next is palatoraphy, usually performed in 1 operation, but occasionally it is performed in 2 also. Then staphylography is the soft palate closure performed by first, followed by the unionophroraphy, of means first hard palate is closed, and after that, if any defect is there left in soft palate, then soft palate is closed. The objectives are for these are the palatal repair to create mechanism capability of speech and deglutition first. See, all the palatal things, they are mostly for speech, deglutition, because they are for functional repairs, and for lip, Mostly aesthetic is the first reason, confidence of the patient is the second thing. Then other surgical, the surgical take operative process for the palatoraphy as a varied techniques for the cleft lip and pair. The hard palate is closed with soft tissues only. Usually no effort is made to create an osseous partition between the nasal and oral cavities. The closure of the soft palate is technically the most difficult operation yet discussed. Excess is the largest problem because of the soft palate is towards the back of the oral cavity. So this is the von Langenbach operation for the closure of hard palate using the lateral releasing incision. So this is the basically cleft of hard palate. So what in von Langenbach technique, there is a releasing incision here and releasing incision here, and the flap is then mobilized to the center. Straight line repair is done here, and this part will later on is filled with granulation tissue, and with virtue of primary healing, it heals. Again, in some variations in this procedure, apart from this, main obstruction is released, and the wound is closed in 2 layers: nasal flap and oral flap. So nasal flap is closed. If you can see the cross section, nasal flap is closed here, and oral flap is closed here. Now, very important is role of speech therapist. The speech pathologists are well versed in assisting children with cleft deformities to develop normal articulation skills. The earlier in life the speech training is started in the patient with cleft deformities, and better and the eventual outcome. The patient may need to undergo speech counseling for several years to produce acceptable speech. For dental point of view, the prosthetic speech aid appliances can also be given so that the speech aid appliance and acrylic bulb is attached to the tooth-bone appliance in the maxilla, and the bulb is fitted to the projection of the and the surface of the soft palate, and it lifts the soft palate superiorly. So this was a small topic of palatal cleft lip and introduction to cleft lip and palate. Now we'll discuss next topic in extraction osteogenesis in orthognathic as well as in cleft lip palate patients. Okay.